Good morning, everyone. Welcome to this session of the ANZ S&M Technologist Symposium. Just a few announcements before we kick the session off. As a courtesy to speakers and fellow delegates, can we please ensure that all mobile phones are switched to silent or off? If you haven't already, there is the WFMB app on your mobile phones. Search MCI Group Event Portal, enter WFNB 18 and your access code from your registration. There's lots of information about the conference on there. And the other thing we need to inform you is that in order to get CPD points for today, you will need to confirm your participation in each session using the QR code displayed on screen with the WFMB app using the QR scanner function. Okay. This session this morning is the Curium Award, with a couple of free presentations at the end of the session. For those that aren't familiar with the Curium Award, it's a scientific presentation by a technologist leading towards innovation in a future role for nuclear medicine. Presentations are scientific in nature, and we wish all the applicants for the award this year the best of luck with their presentations. Just an update from last year's presentation. Last year's winner was Lisa McFarlane from Peter Mac, and her presentation was on insulin and FDG. That resulted in an application for mobile phones and internet being developed, and that's actually now gone live as of this week. So it's really great to see something that came through the Curium Award actually coming to fruition. And so if anyone's interested in that app, it's Peter Mac FDG. If you put that into Google, it'll come up with your insulin calculator. Okay. Russell, would you like to introduce the first speaker?
Okay. Everybody's far enough away from us to not get... Hello! Okay, the first speaker is Brittany Robinson, and the title of her talk will be on fluorinated FDG PET-CT, cardiac sarcoid imaging, monitoring ketone levels to avoid inadequate suppression of physiologic myocardial uptake. Brittany.
All right, good morning, everyone. The topic I'll be discussing today involves PET-CT cardiac sarcoid imaging and investigating the use of capillary and urinary ketone levels to avoid inadequate suppression of physiologic myocardial uptake. Sorry, how do I click ahead? The button there. Oh, yep. Guidelines for cardiac sarcoid imaging using PET currently recommend low-carbohydrate, high-fat diets with fasting to suppress physiologic myocardial FDG uptake. However, as I'm sure many of you have experienced in clinical practice, adequacy of dietary preparation is often uncertain, particularly given concerns regarding the accuracy and reliability of self-reported food intake. After researching current literature regarding this topic, we came across a study from the Journal of the American Heart Association that showed direct intravenous infusion of ketone bodies could actually suppress physiologic myocardial FDG uptake. This article, together with some clinical cases whereby patient management was drastically altered by scan outcomes, prompted us to begin our own study aimed at investigating the potential use of capillary and urinary ketone levels as markers of dietary fasting preparation. Okay, so sarcoidosis is a systemic disease of unknown etiology that is characterised by the formation of non-necrotizing granulomatous inflammations. These can subsequently become fibrotic. Patients with cardiac involvement demonstrate a poor prognosis, with cardiac sarcoidosis accounting for 24% of patient deaths, as mentioned in a Radiographs article published in 2015. Clinical manifestations of myocardial sarcoidosis are non-specific and can include ventricular arrhythmias, pericardial effusion, pulmonary hypertension, congestive heart failure, and sudden cardiac death. Only 40 to 50% of patients that were diagnosed at autopsy were found to have been correctly diagnosed over their lifetime, according to a paper in the Archives of Medical Science. This clearly highlights the importance of early detection of the disease. Current investigative techniques involve the assessment of clinical criteria, invasive and non-specific endomyocardial biopsies, and imaging modalities such as cardiac MRI and fluorine-18 FDG PET. Upon diagnosis, the treatment options available to patients are limited and each have their own associated risks and negative side effects that must be considered. Some of these include corticosteroid treatment, pacemaker therapy, implantable cardiac defibrillator insertion, or heart transplantation. FDG PET plays a major role in the diagnosis, restaging, and monitoring of cardiac sarcoidosis, and has demonstrated its usefulness in guiding the intensity and duration of anti-inflammatory therapies. We retrospectively collected data from a series of patients within our department who underwent FDG PET scans for investigating cardiac sarcoidosis. We recorded information such as patient dietary records, fasting status, diabetic status, BSL, blood sugar levels, height, weight, and patient age. Initially, as per departmental protocol for cardiac sarcoid imaging, our patients were required to adhere to a low-carbohydrate, high-fat diet for 24 hours with an overnight fast of greater than 12 hours. Patients were also required to have a resting myocardial perfusion scan in conjunction with the PET scan. Since commencing this study, our protocol had been updated with alterations to our patient preparation. The patients we reviewed then had to be placed into 3 groups. We have group 1, consisting of those who did not have their ketones tested and adhered to a 24-hour diet with 12-hour fast, and these patients solely relied on their self-reported food intake. Group 2 is comprised of those who had a 24-hour diet and 12-hour fast, but also had their urinary and capillary ketones measured prior to the injection of FDG. And for our third group of patients, they had a 48-hour ketogenic diet with a 18-hour fast and had their ketones measured prior to the injection of FDG. Ketones were tested using the Siemens multi-strips test for urinalysis and the Freestyle Optium Neo ketone monitoring system for capillary measurement, and these results were then summed for a combined reading. Following the PET scans, we reviewed the reports of each of these patients to gather a descriptive analysis of the findings of the studies. We categorised the patterns of uptake for our patients as either no uptake, focal uptake, or diffuse uptake. For the purpose of this investigation, we chose to combine the patients that exhibited no uptake or focal uptake, as these were patients that our nuclear medicine physicians were able to report as having suppressed physiologic myocardial FDG uptake. This will be referred to as pattern A uptake. Pattern B uptake refers to the patients that demonstrated diffuse uptake, which could be considered as either inadequate suppression of myocardial glucose uptake or diffuse cardiac sarcoidosis. Our study involved 84 patients, 51 male and 33 female, ranging from 22 to 79 years old, with an average age of 54. The average BMI for our patients was 29.3 kilograms per metre squared and ranged between 19 and 49. BSL was measured from 3.1 to 14.5 millimoles per litre, and the average BSL was 5.52. There were 39 patients in Group 1, 26 patients in Group 2, and 19 patients in Group 3. 27 patients in Group 1, our group that did not have their ketones measured but had followed the 24-hour diet and 12-hour fast, had pattern A uptake, which is either focal uptake or no uptake, as you can see in the reminder images up in the corner there. The remaining 12 patients demonstrated pattern B uptake, and of these 12, the reports for 2 of the patients confirmed the presence of cardiac sarcoidosis. The reports for the other 10 patients with pattern B uptake were inconclusive due to inadequate myocardial suppression from incomplete fasting or improper dietary preparation. Group 2 had 2 out of the total 26 patients demonstrating pattern B uptake. Both of these patients had inconclusive results due to inadequate myocardial suppression from fasting or improper dietary prep. The remaining 24 patients had pattern A uptake. 17 patients in group 3 exhibited pattern A uptake, and 2 patients had pattern B uptake. 1 patient was confirmed to have cardiac sarcoidosis following their PET scan. This patient had ketones that measured at 5 millimoles per litre, and that's the combined urinary and capillary ketone levels. The other patient's results were inconclusive, again due to inadequate myocardial suppression. The reports for 10 out of the 39 patients in group 1 were inconclusive at 26%. Since implementing ketone testing, referring to our groups 2 and 3 combined, the results for 3 out of 45 of the patients, or 7%, were inconclusive. The combined urinary and capillary ketone levels for patients in groups 2 range from 0.2 to 9.4 millimoles per litre, with an average of 2.05. And group 3's ketones were recorded between 0.1 and 5.4, with an average of 2.5. For 15% of patients in group 2, the reporting physician confirmed that there was excellent suppression of physiologic myocardial glucose uptake. This was also reported for 42% of patients in group 3. To aid in my discussion, I just wanted to quickly highlight one of the cases that helped prompt our investigation into ketone measurement, and this involves a 70-year-old male with known sarcoidosis involving the myocardium and lungs. He was diagnosed in 2012. He'd been taking a combination of prednisolone and methotrexate in a bid to manage the disease. He suffered from hypertension, and his most recent ejection fraction was estimated at 44%. In April of 2017, he had a resting MPS plus FDG PET scan. Unfortunately, we weren't measuring ketones at this time, so I don't have any initial ketone measurements. However, it's still a very powerful case that highlights the importance of making the correct diagnosis. The sestamib uptake on the MPS appeared to be homogeneous, with no focal perfusion abnormality, and the left ventricular ejection fraction was estimated at 36%. Prior to the injection of FDG, we recorded the patient's BSL at 3.1. As you'll notice from this PET scan, there's intense FDG uptake demonstrated throughout the lateral and inferior wall, with moderate uptake in the mid to distal anterior wall and septum. The reporting physician noted that the increased FDG uptake throughout the myocardium was suggestive of incomplete metabolic suppression, despite the low-carb, high-fat diet and 12-hour fast. They also noted that it could be related to hyperinsulinism in the setting of insulin resistance from prednisolone. However, given the clinical history of reducing ejection fraction, a combination of active disease and incomplete suppression could not be excluded. It was suggested that a repeat study be performed with the possibility of a longer duration on the ketogenic diet with higher fat ingestion. 1 month later, following a discussion with our consultants, the patient was instructed to undergo 3 days of the low-carb, high-fat diet with an OptiFast fatty meal replacement on the 4th day, plus a 12-hour fast before the scheduled MPS and PET scan on day 5. Prior to the injection of FDG, we measured his BSL at 4.2, and we recorded his capillary and urinary ketones and found them to be 1.3 and 0.5 respectively. As you can see from our next image, there is no abnormal FDG uptake throughout the left ventricular myocardium with resolution of FDG uptake. There is no evidence for active myocardial inflammation. Since conducting this study, this patient returned for yet another scan in October of last year with recently increased dyspnea, new cardiomyopathy, and a further decrease in a left ventricular ejection fraction down to 35%. His resting MPS images were reported as suboptimal due to subdiaphragmatic activity. However, they did show a dilated left ventricle with decreased sestamib uptake in the apex and lower anteroseptal wall. His ejection fraction for this MIBI test was estimated at 32%. This time, the patient was instructed to follow the diet for 48 hours with a 20-hour fast. His BSL was measured at 4.3 and his urinary ketones 1.5 and capillary ketones at 0.9. Upon reviewing the PET images, the reporting physician concluded that there had been excellent suppression of myocardial FDG uptake that was less than that of left ventricular blood pool activity and that there was no abnormality detected. Due to the non-specific manifestations of the disease and irregular myocardial involvement, cardiac sarcoidosis remains a diagnostic challenge, and there are significant management implications for the patient if the incorrect diagnosis is made. After observing cases such as the one I've just described, we identified the need to investigate other methods that could be potentially used in order to confirm adequate dietary preparation, and this in turn will support physiologic myocardial suppression. For patients in group 1 who did not have their ketones measured, we noticed a higher incidence of patients presenting with pattern B uptake at 31%, and this then compared to the 8% and 12% of groups 2 and 3 respectively. Since we began measuring ketones, our consultants have been more conscious of ensuring patients are within a more appropriate ketogenic range. If they were not satisfied with the patient's ketone levels, the patient would then be rescheduled to a later date with emphasis placed on instructions to adhere to a low-carb, high-fat diet over a long time period. This is one of the reasons why we are now seeing fewer patients with pattern B uptake in groups 2 and 3. To emphasise this point, I just want to quickly refer back to our earlier results where we compared the percentages of inconclusive reports for group 1 with the combined results for groups 2 and 3. As you can see, since implementing keto testing within our department, we are seeing a greater number of confirmed PET reports. As mentioned previously, our patient preparation requirements were adjusted partway through this study so as to extend the 24-hour diet, low-carb, high-fat diet, and 12-hour fast to a 48-hour low-carb diet with 18-hour fast. And our results show that there is a slightly higher combined ketone average of 2.5 millimoles per litre for patients in group 3 who had undergone the longer diet. 42% of those patients were reported to have had excellent suppression of physiologic myocardial glucose uptake, confirmed by the presence of higher ketones, as opposed to only 15% of patients in group 2. These results suggest that a prolonged low-carb, high-fat diet of 48 hours enables higher capillary and urinary ketone levels than a 24-hour diet. They also indicate that at higher ketone levels, the consultants are more confident in a patient having successfully followed ketogenic dietary preparation and are therefore more confident in making diagnosis confirming or denying the presence of cardiac sarcoidosis. We used to rely on self-reported food intake alone in order to gauge whether patients were in fatty acid metabolism, thereby assuming physiologic myocardial suppression. In practice, this can be quite an unreliable method, often leading to repeat scans being suggested. Recent literature by the American Heart Association found that direct intravenous infusion of ketone bodies could reduce physiologic myocardial glucose uptake by up to 50%. Our retrospective study involving 84 patients investigated the potential use of these ketones as markers of adequate dietary preparation. From the results, no direct conclusions can be drawn. However, it does appear that the higher ketone levels provide more diagnostic confidence for our reporting physicians when determining the presence or extent of cardiac sarcoidosis. Currently, there is little research that investigates ketone levels and the pattern of FDG uptake within the myocardium. Further prospective evaluation of the role of these ketones as markers of adequate dietary preparation for cardiac sarcoid imaging is warranted. Thank you.
Okay, we've got time for a couple of quick questions. There are 4 microphones around the room. If people could please avail themselves of those when asking the questions.
Given the complexity of the protocol and the potential for false positives and false negatives, obviously with FDG being accumulated in the normal heart, have you considered using alternatives like gallium-68 citrate, given that gallium-67 citrate's used for sarcoidosis?
Not currently within our department, but that would be another avenue to take back and have a chat to the doctors about.
Hi, excellent paper. I thought that was very interesting. Did the difference in terms of prevalence of type B presentation, did that not reach diagnostic confidence? Was there a p-value between the two groups?
We didn't get down to any sort of statistical analysis like that, unfortunately. I feel as though this study could really be driven to provide some much better results. Unfortunately, retrospective analysis such as this one, we didn't quite go into that much detail, but I can definitely see an avenue for that. Thank you.
Last question, please.
Yes, hello from Miyagawa from Japan, and I'd like to ask you in Japan, we'd like to use the free fatty acid before the testing, FDG testing. How about that? Your
Yeah,
condition?
the article that I accidentally skipped over quite quickly at one of my second slides was a very good article where they discussed all of that yes, this is the one, with the ketone body infusion. They go into quite a lot of detail in this particular article. I'm sorry we don't measure it at all, but interesting article for anyone interested in looking at this topic.
Okay.
Thank you.
Thank you, Brittany.
Thank you very much.
Okay, our next speaker is Scott Evans, and his talk will be on implementation of a new standard, SPECT-CT in cardiac amyloidosis.
Thank you very much. Morning, everyone. The 2 images I've got on screen there are basically of a negative and a positive myocardial uptake for amyloidosis. The scan on the right shows the actual uptake within the left ventricle most prominently, and basically this is caused by conditions which was that the advance? No joy. It didn't like bouncing. There we go. Thank you. So the amyloidosis is basically caused by two main diseases. They're basically both mutations of expression of genes. The main disease is basically caused by amyloidosis of transthyretin. Transthyretin is formed in the liver, and basically transthyretin is an actual transport molecule for vitamin A and T4. And they basically form these little bundles that form into amyloid, and they get into all the wrong places. Amyloid light chains are formed in plasma cells in the bone marrow, and they basically get in also the wrong places, which is the myocardium. They basically cause stiffening of the heart and prevent it from actually being able to perform its job as a pump. Now, there are some treatments for this, but those treatments need to basically be started sooner rather than later. The actual consequences of not starting treatment is ultimately death. Now, the treatments can be quite good, but the sooner you start them, the better. And the actual amyloid itself actually increases over time, and the main way that people have been making this diagnosis over the years is through cardiac biopsy. And the problem with cardiac biopsy is it's not really a good screening test. You wouldn't want the entire family to front up and actually try and have that piece of their heart taken. So fortunately, we actually have a test in nuclear medicine which uses both diphosphonate of traces, and they localise well into affected tissue. Genotyping can be performed, but it won't diagnose if the heart is actually involved. And technetium labelled DPD, which is technetium diphosphonopropanate dicarboxylic acid, determines if cardiac infiltration or uptake is significant. There is a planar analysis that has been used over the years with this test, and basically the planar analysis has been proved to be effective in diagnosing cardiac amyloidosis, but I have a very simple issue with this method of analysis, and you can see scans top and bottom here. The top scan is a negative scan, and basically you see the red circle is an actual a cardiac region drawn over, in this case, the blood pool, and the blue circle next to it is a background region. And the scan on the top and bottom, you can see there's a negative scan, the bottom scan is a positive scan for amyloidosis. And the main issue with the planar analysis is all of the actual structures that are positioned, unfortunately, under the background region. You can get uptake in the lungs, bone, and liver, and basically they'll affect that background region. Now, SPECT-CT give obvious advantages to actually making this diagnosis over the planar analysis, and you can see the cardiac amyloidosis scan. The SPECT-CT on the bottom row there is actually showing a beautiful uniform uptake in the actual myocardium. The top scan, the negative, basically you can see the cardiac blood pool, and it basically gives you a great idea of how much more effective SPECT-CT is in making this diagnosis. So in our department, we have an elaborate protocol, which was basically arranged so we can actually test out some other parameters of timing, which basically we'll be able to drop some of these parameters out of the imaging. But at 1 hour, we do a whole body sweep, static chest, and a SPECT-CT, and at 3 hours, we do a whole body sweep, static chest, and a SPECT. And basically, we use the CT acquired at the initial time point for attenuation correction. We had 59 patients, and we got SAS approval for each of these patients. Mean age was 66.8 years. Because we were using DPD, we had to get SAS approval for each individual patient. We have ethics approval there, and basically most of our patients were referred to us from the Westmead Amyloid Clinic. We had 52 patients from them. Cardiology heard about the project, and they tacked on another 7. And most of the patients, basically, if they're for either 1 or 2 reasons, either to detect the presence or extent of cardiac amyloidosis, and the other group were people who were known to have a parent with the actual condition, and cardiac amyloidosis can be a hereditary condition where children inherit it from mum or dad, and basically it's used as a screening test to determine disease status by avoiding a biopsy. So this is the actual article for the planar analysis as it's been used over the years. They basically have a ratio of those heart to the background ratio, heart to background region, and the ratio needs to be less than 1.5 to be normal scan. Now, the SPECT-CT analysis that basically I developed uses a aortic arch region, which the user defines, then basically a myocardial region, and the ratio calculates a ratio between the heart counts per pixel to aortic arch counts per pixel. And the aortic arch being an actual blood pool region, it means anything greater than blood pool is abnormal. So the results. This is one of the scans we did. This is a 76-year-old male. He has the transthyretin mutation. He basically has a number of children, but he has 2 daughters that actually have inherited the gene from dad, and this is the family photo you don't want to have. Dad on the left, he has quite intense myocardial uptake. The daughters don't have the actual myocardial uptake yet, but they'll actually require following up over time. They'll have follow-up scans as well as some of the treatments to actually prevent them from developing the disease. And in terms of follow-up scans, we have done a number of patients with that, and this is an example of a 52-year-old male when he came to us in 2016 and he came the year following. He was, his father had died basically as a 78-year-old, and basically his son has already started to develop actual peripheral neuropathy, which is some of the actual additional diseases that these patients get. He doesn't actually have any cardiac symptoms yet, but you can see the planar images there for the 2 time points, and you can see there is some slight uptake on the actual heart that looks like myocardial uptake. On the SPECT, the picture to the right of each of the planars, you can see that uptake is really quite profound. And if you can see it does actually increase between the 2 time points. So the planar analysis was normal, and basically on both these occasions. The SPECT-CT heart to aorta analysis had a value that was greater than blood pool and was defined as abnormal. Unfortunately, that wasn't an uncommon event for us to have planar analysis failing. And basically, here's another patient where you can see the whole body sweep and the SPECT images with quite profound cardiac uptake on both on the early and delays. The planar analysis basically had ratios which were less than 1.5, but the SPECT-CT analysis had ratios greater than blood pool. And basically, you can see the uptake is increasing over time, with the 3-hour ratio being much greater than the 1-hour ratio. So this is our patients overall. Basically, you can see there's top here, we've got the actual planar ratio numbers. At the bottom, we've got the SPECT heart to aorta ratios. The three columns you see there are the actual uptake in the heart, blood pool column on the left, faint myocardial uptake in the middle, and increased myocardial uptake on the right. You can see there's a number of patients where the planar analysis failed to detect the actual uptake as being abnormal at the 1 hour time point, but the SPECS heart to aorta ratio was able to pick up those points. 3 hour ratio, the same thing occurred, where basically the blood pool, where the actual faint uptake is basically for the planar analysis is well below the actual threshold of 1.5 in 4 of those patients, as well as a number of the actual SPECS, as well as the increased patients as well. In terms of the table analysis, breaking that down a little bit further, the planar analysis failed to detect all of the faint cardiac uptake patients, and 2 and 3 of the actual increased myocardial uptake, representing cardiac amyloidosis at the 1 and 3 hour time points, where the SPECT-CT analysis using heart to aorta ratio detected all points at all values. In terms of our actual types of patients, we had quite a selective group. There were basically only 1 patient with amyloid light chains. We had 14 wild type amyloid patients, and all of these patients had uptakes well in excess of their threshold. With the amyloid transthyretin and subtypes transthyretin groups, we had a spread of values. The ones that are above the actual threshold of 1, that basically represents patients with disease. The patients with values below 1, these represent the children of the actual patients, family members who have actually been already picked up with the actual cardiac amyloidosis, and these people will need to have ongoing follow-up and basically treatment. So planar analysis is ineffective in detecting low-grade uptake, which is essential to initiate treatment. SPECT-CT heart aorta ratio is sensitive to detecting lower uptakes within the heart, provides a means of detecting disease and initiating treatment. SPECT-CT heart aorta ratio takes advantage of attenuation correction and scatter-corrected imaging to provide a reliable longitudinal assessment for cardiac amyloidosis. This SPECT-CT analysis based on heart and reference region analysis has been implemented and provides a sensitive method for cardiac amyloidosis detection. Thank you very much.
Thank you, Scott. Any questions for Scott? We've got time for a couple of questions.
Thanks, Scott. Just a quick question, actually. In regards to the 3 hour uptake, were you very strict on that and with the 1 hour and the 3 hour uptake, or was there a buffer that you had time with, especially on a scheduled day? What was the limits, upper and lower?
Basically, if the patient wasn't within about 1/4 of an hour of the actual 3 hour time point, I excluded them from the analysis. There was one patient in particular where the 3 hour became 4.5 because of camera breakage. So that was well excluded out of the study.
And have you heard of the Pellegrini score?
I have, and that's what that planar analysis is.
Yeah, okay. All right, thank you.
That's what we basically have picked up wasn't actually as good as what we hoped. It was good for an increased heart uptake, but basically in those faint cardiac uptakes, it didn't actually pick up those patients having disease, and they were the ones you want to actually get treated.
Scott, can I ask how sensitive this technique would be for various operators? So if I sat down with your data and did all the regions and did everything according, would I get the same spread of?
You should. The actual comes down to double-clicking on the aorta and basically then drawing circles around actual outlines of the heart. It's something I haven't actually tested as yet, but basically we're actually developing the software, and version 6 will be coming up, and that would be part of that.
I mean, it's interesting because there's a lot of people who will sit down and you draw regions and you get various curves and numbers and whatever.
For sure.
In terms of different observers, what sort of variation do you get?
I haven't actually measured that, but with the actual program itself, you can actually see with the heart there, I'll be able to actually adapt a boundary technique using the CT. The actual aorta is already defined by the actual CT.
So it should be pretty tight.
So it actually will tighten the actual region around. So it's not just like drawing the barn around the actual heart. It's basically we'll be able to track in around.
Excellent.
You, Scott.
All right.
Oh, hang on. Sorry. No, we've got one more.
Hello.
Yes, very nice talk. And I might miss, does this tracer accumulate similarly on wild-type transthyretin, mutant transthyretin, and AL amyloidosis?
It does, but unfortunately in my little group I only had the one. I think that was a feature of my actual clinic where we haven't had as many amyloid-like patients come through, but we did have one in there and that was really quite positive.
Thank you.
Don't drop the remote.
No one else? No. Okay, thank you, Scott.
Our next presenter is Suzanne McGavin, and she will talk on expanded scope for nuclear medicine scientists administering peritumoral injections under ultrasound guidance. Please welcome Suzanne.
Okay. Good morning, colleagues. My name is Suzanne McGavin. I'm the statewide educator for Queensland Health Nuclear Medicine. So my research project is about expanded scope for nuclear medicine scientists administering peritumoral injections under ultrasound guidance. The button. Got it, okay. So before the whispers in the crowd start, I just want to have a look at some literature surrounding the injection techniques for lymphoscintigraphy studies. The AENM guidelines state that the optimal injection technique has been subject of lively debate. After almost 20 years of experience, it's generally accepted that both deep and superficial injection methods are valid. Other literature says numerous things, pretty much concluding that the multiple injection techniques have several proponents for each technique. So with this said, this is not a paper to engage in that discussion. This is a project that goes about what else the literature says, that these injections should be performed by professionals which has specific training in the procedure. And at this time, there has been no defined definition of required training that has been validated. So this is how this project was instigated. This is for those facilities who are requested by surgeons to perform the peritumoral injections for their lymphoscintigraphy patients. The problem with this peritumoral injection method is it sometimes is required up to 3 different disciplines to coordinate together to perform the study. These disciplines sometimes come from various departments. This induces sometimes delays on our patients. Having a nuclear medicine consultant, a sonographer, a nuclear medicine scientist, and sometimes a nurse in a room results in this procedure being quite a high labour resource, and there are potential lower options. These high labour resource staff are sometimes called away to do specific duties that only they can perform, again resulting in increased waiting times for our lymphoscintigraphy patients. So the aims of my research project was to identify if with adequate training, a nuclear medicine scientist can expand their scope to perform all aspects of the peritumoral procedure. This project would hope to increase efficiency and reduce costs, providing an increased model of care for our patients. The project aims to create a sustainable training model, which can be transferred not just across Queensland, but across Australia. It also hopes to improve and maintain the skills of our current nuclear medicine workforce, increasing their capability. And also to continue to develop innovation within our community so that we are moving forward as the changes of healthcare requirements happen. Sorry. To do this, I thought it was quite a simple method, 5 steps. I think the first thing before engaging in any expanded scope or research project is to consult with the wider nuclear medicine community outside of the walls of where you work, because we all do things quite different. Now with this project, that was very important because I wanted to ensure that I was going on a path which the community might be responsive for. Next was to consult our legal requirements and accreditation, including the MRPBA, Radiation Health, and the Queensland Health Legal Team, regarding the licensing and accreditation requirements of an expanded scope. At this time, there was funding available from the Allied Health Professions Office of Queensland to develop expanded scope within the system. I would then apply for this funding. After receiving this funding, the hope was to invite all Queensland sites to participate in this project. That was important because as a statewide educator, I need to ensure my projects are able to be dispersed across all our geographical locations. The final step was to evaluate the project and submit this final report and print it and present it. So for those who may be unaware, expanded scope is a discrete knowledge and skill base additional to the recognised scope of practice of the profession. Tasks are usually undertaken by other professions. However, over time, expanded scope of practice may become part of the professional's full scope of practice. The outcome of any expanded scope project really should be to develop a modern, responsive and more effective allied health workforce to improve our patients' access to high-value healthcare. It should also create a more effective and more efficient use of the allied health workforce to achieve better outcomes again for our patients, the community, and also the workforce at large. There are 4 priority areas in which an expanded scope should try and address. To obviously expand the scope of practice to improve patient access, develop evidence and promote research within the profession, develop a sustainable workforce, increase capacity and capability of our members, and also to maximise the enablers and address the challenges that we're presented with within the healthcare system. So how did I go? Well, after consulting sites across Australia, including public, private, large and small, 85% of the sites were supportive that with an appropriate documented training pathway, the expanded scope was a feasible idea. I received comments such as it would help with workforce stability. The nuclear medicine scientists are sometimes more experienced in injecting than those who are currently performing the procedure. It would help with workflow. It's logical. It's within our ability. This would create a much quicker procedure and increase the standard of the procedure. So with those positive comments, I moved on to step 2. So consulting the MRPBA, Radiation Health and the Queensland Health Legal Team, all 3 teams agreed that with a documented training pathway, the task would fall within the legislative and legal requirements of professional skills. They said that I must demonstrate a clear training pathway and an established competency to perform the task. There must be some method of documenting which staff have received this competency, and you must have it signed off and ensure that you are covered under your professional indemnity insurance. The third step was then to apply for funding. Now, if any of you out there have ever applied for funding, it is quite an arduous process. There is lots of paperwork, lots of evidence needs to be gathered, and a real big chunk of paperwork needs to be submitted. So in order to do this project, it was vitally important that I engage the stakeholders, particularly those who we may be encroaching on their territory. The main thing of a model is it needs to be sustainable, that it's not a one-off solution to a problem. I then had to apply for ethics to ensure that we could implement it within our health service, and then also attend a variety of workshops conducted by RPOC and sit through a number of interviews. There was also terms regarding the funding, and then the training needed to be undertaken and implement the expanded scope. Within this step, I need to be able to develop the package. I was extremely fortunate to use a variety of different networks and link with the Australian Institute of Ultrasound to develop a 2-day intensive nuclear medicine specific breast ultrasound course. This also then led me to assist in developing competency packages and trial them within Queensland Health and make them transferable to across Australia. I gained approval from the Ethics Committee so that it could be implemented within our service, and then applied for the funding. So the funding was open to all Queensland Health allied professions. This includes physios, OTs, pharmacy, quite large professional groups, and only 10 projects were selected for funding. We were the only nuclear medicine project to have ever submitted this kind of work. I was extremely fortunate to receive over $50,000 and be one of the selected funded projects to fund a project officer and implement training and a pathway. So I've just put a small snapshot of some of the documents in the training package, outlining guidelines, where to find the information and the requirements of the training package. This also includes the breast ultrasound course, which is now being published in the 2018 syllabus. It's black and white, available for everyone. And that picture there is just a simulation of some of the training techniques that were used in the course, using a chicken breast to simulate breast tissue and a grape to simulate a lesion. Also within the package, there's obviously criteria to ensure that you have observed practice and supervised practice in each component of the procedure, which would then lead you to have a full competency sign-off, making sure that every single step of the procedure, the technologist is competent in. After we received funding and developed the packages, we invited all of Queensland health facilities to be involved in the project. 3 sites were able to engage in the project as they could meet the funding requirements. 8 staff across Queensland Health then were supported to attend the ultrasound course. 2 Queensland sites have now successfully implemented the expanded scope with improved patient outcomes, now providing a new service within that department. From the initiation of this study and the development of the course, a further 8 nuclear medicine scientists outside of Queensland Health from across the country have now attended the course, and this has stimulated interest for the course to be run in other states. For step 5 to evaluate the project, I successfully submitted reports and did an evaluation to RPOC. The project was presented at the Health Roundtable Awards, which is a conference of innovation within our healthcare to help other services find how they can promote themselves and develop progress in their profession. It was also presented at the Expanded Scope of Practice Symposium, which received positive feedback via other allied health colleagues. It's now been published on the RPOC Expanded Scope Strategy website. It's really important with any research project that's undertaken that it's used against an evaluation framework. The National Health Performance Framework of 2009 was chosen to see if this project fit within the domains of health system performance. I'm very happy to say that we received positive outcomes in all 6 domains of health system performance, making this a successful project. Just looking at one of the sites, the initiation of this project initiated other implemented changes within this particular procedure. And for further information, Saturday, P100, you can find all that extra information there. Things like new referrals, increasing patient flow pathways, and all this also meant that we reduced the patient waiting time of our patients quite significantly, up to 35-minute reduction in waiting time, which was fantastic. The expanded scope itself, going from those 3 higher labour resources to 1 nuclear medicine scientist, has a p-significant score of less than 0.05, making that quite largely statistically significant. Looking at the enablers and challenges of the project, having a high belief in the impact of patient outcomes really drives any research project. Making sure that you have support from the professions that you're going into, and also making sure that you have governance structures which help you provide evidence and increase the feasibility of any project. Challenges to any project, I'm sure it's not news to say that there are large cultural barriers to change within our system. And also assuming that we have communication between everyone is quite an assumption. And that assumption for myself in this project meant that this project stopped and started numerous times until these issues were dealt with. The conclusion of this project showed that it is viable for a nuclear medicine scientist to expand their scope in peritumoral injections. There is now a nationally available program and pathway for all facilities to undertake this, and there's statistically significant results to reduce labour costs. Other procedural changes resulted in decrease in waiting time and overall produced an improved model of care for our patients. This button is not going well. I think this project will hopefully engage in lots of discussion regarding expanded scope. It really demonstrates that I have been able to utilise the existing skill set of our profession and then combined a comprehensive training and education pathway to result in expanded scope. This then increases efficiency within our healthcare system, and this model can be transferred and used for other avenues within the nuclear medicine community. It's really important that we continue to grow and use the skills of our profession so that we develop along as our profession develops. It also hopes to expand our horizon and ensure that we remain an integral part of the allied health professional community. So I just leave you with the pondering thought of what else can we investigate to start to look at our expanded scope process. Thank you.
Thanks, Suzanne. Has anyone got any questions? Oh, yep, there we go.
I just had a quick question. A couple of months ago, I actually had a clinical site that sent me a whole bunch of data because they felt that when they had a patient had a hook wire in place before they did the scan, that they actually had less detection of the sentinel node. As it turns out, that the actual only difference had nothing to do with this hook wire, it actually had to do with who did the injection. So what's really important is that have you got any data that actually shows the outcomes in terms of whether it's actually improved the localisation of the sentinel node due to better technique or whether it hasn't had an impact?
Interesting question. No, for this particular study, didn't quite look at that data. Just having a look at, you know, making sure that we are using the correct technique that we can be aware of. But I think that would be a great avenue. But I wouldn't like to put a patient and say, well, that injection wasn't correct, but let's see what happens. So, yeah, it would be interesting to have a look at the different injection techniques of each person, but I think that's why this project, I think, really uses something that creates a standard, that at least we know that anyone performing these injection techniques has gone through the same structure of competency to ensure that they're all at the same level, hopefully.
Anyone else?
Again, an excellent presentation. I know that some people from Western Health here in Melbourne did a similar project with the health department here as part of advanced practice for allied health. I think the message seems to be that we are doing this in little isolated groups, and I think it's only at a gathering like this that we see the potential for perhaps Australia-wide innovation rather than doing it in little tiny groups that nobody outside our own city basically knows about. But an excellent presentation and more power to us.
Thank you.
Okay. That concludes the Curium presentations for this morning. We wish those 4 presenters the best of luck. The next speaker is Julie Crouch, talking on the optimum protocol for gallium-68 PSMA within a private practice.
I've been told not to drop the button. Okay, so good afternoon, everybody. I'm going to be talking about gallium PSMA protocols and imaging within the private practice setting. So gallium-68 combined with prostate-specific membrane antigen, PET-CT, is recognised as the diagnostic imaging tool in the assessment of prostate cancer. It has higher detection rates than other tracers. It has improved diagnostic capabilities that impact on treatment options for patients. The imaging protocol varies both within the clinical practice and also within the literature. I'll be discussing our experience in developing the optimum protocol within a busy private practice, where we've scanned over 800 patients with gallium PSMA imaging to date. There are many protocols that are clinically practiced and are also in the literature. Some of these include a standard single time point, where the tracer is injected and the scan occurs 1 hour later, a whole body scan. Some protocols include a diagnostic CT with contrast of the abdomen and pelvis 20 minutes before the PSMA scan. Some scans have a dynamic image 15 minutes after the tracer injection, followed by a whole body delay at 70 minutes. Some protocols include early and delayed imaging of whole body, for example, at 45 minutes and at 2 hours, with the patients well hydrated between these two time points. There are different PSMA ligands to consider, the most popular being HBED and INT. Some protocols administer diuretics at the time of injection to increase diuresis, improve image quality, and exclude artifact from the urinary tract system. Some protocols, although not within Australia that I know of, also include rectal filling with negative contrast agent. I'm going to focus on our current practice. Our operational hours are between 7 a.m. and 5 p.m. 5 days a week. We have one supplier of FDG in the state, and the first injection is at 7:30, and we can do between 10 and 14 FDG patients on a daily basis. A diagnostic CT of the abdomen and pelvis is included. Chest, abdomen, and pelvis is included in a lot of these patients. The gallium scans are usually scheduled in the afternoon because of the FDG capacity. We also have research considerations. We do a lot of Alzheimer's research, and appointments are dependent on the availability of the tracer, especially as most of the tracer comes from Melbourne. I'm based in WA, so that's one of the challenges as well. We also have the logistics of preparing the gallium PSMA, such as the age of the generator, quality control results, and yield issues, which impact on the number of patients that you schedule, as well as complications that can occur if you have problems with yield or QC. So between May 2015 and July 2017, we scanned 654 patients for gallium PSMA. These patients were retrospectively analysed, looking at their images and also their technical data. Gallium PSMA was produced using the INT ligand with a symptomic synthesis unit, and TLC and HPLC quality control was performed before injection. Fasting was a minimum of 2 hours, and each patient was well hydrated. The average activity was 180 megabecquerels, plus or minus 25%, and the acquisition mean uptake time was 45 minutes. Some patient had diagnostic contrast CT of the abdomen and pelvis just prior to PSMA imaging. Other patients had 50 ml of Omnipaque 350 contrast 30 minutes prior to imaging. Those patients didn't have a diagnostic CT because they'd had one previously in the last few weeks. Some patients didn't have contrast because there were contraindications, such as renal failure. The total acquisition time was between 20 and 30 minutes for the whole body, and the delayed imaging was anything between 10 to 15 minutes for acquisition. We always have a doctor on site for the administration of the contrast. Some of the results from the analysis include selective delayed imaging was performed in over 45% of cases. The doctor would review the whole body and decide if delayed imaging was required. This was usually in cases where there were equivocal findings or no uptake at a metastases when there was a high degree of suspicion. The delay often showed metastases due to washout and other tissue, due to retention in tumour. Confirmation of artifact and movement of excreted tracer in the ureter, and also frequently subtle findings on initial imaging, could be resolved on delay images, excluding suspected metastases. 85% of the patients had contrast prior to the PET-CT. This assisted with diagnosis and delineation of the urinary tract system. The contrast also enhanced defects from transurethral resection of the prostate when prostate was in situ. The next three cases will demonstrate how delayed imaging had an impact on the clinical diagnosis. The first patient is a 67-year-old who was treated with surgery and radiotherapy to the prostatic bed in 2003. He had recurrence of pelvic lymph nodes in 2015 and had salvage nodal pelvic radiotherapy. His PSA was 1.19 when he presented for a PSMA scan. The scan showed subtle uptake of lymph nodes on initial imaging, which is better emphasized on delayed imaging and is in keeping with a diagnosis of small volume metastatic disease. The second patient was a 69-year-old with a PSA of 6.42. He had a Gleason score of 9, and the MRI had features of extraprostatic disease. Sorry, I'm having difficulty seeing my images. The initial scan shows subtle uptake, but there's increased activity on the delayed imaging, which is in keeping with primary disease of the prostate, being marked more on delay than initial imaging. The third patient, sorry, that's another view of that same patient B. And the third patient is a 64-year-old who was treated with robotic prostatectomy in 2007. He had an increased PSA of 0.15 in August 2016, and at the time, the gallium PSMA scan showed subtle activity at the posterolateral aspect of the prostatectomy bed. The patient was observed as there was no other symptoms. He represented in February 2018 with a chemical relapse and a PSA of 0.24. The gallium PSMA scan, it was difficult to see any activity on initial imaging. However, on delayed imaging, there's progressive uptake at the right posterolateral region on the delay in keeping with local recurrence. The next three slides are examples of how contrast has helped with the clinical diagnosis. So patient A, the first image shows a suspicion of nodal metastases. However, the second image shows that contrast pacification of the ureter confirms excreted urinary tracer rather than a small nodal metastases. In the second patient, increased activity could either be tracer uptake in the urinary tract or nodal metastases. If you look at where the arrows are pointing, there is contrast opacification in the ureter, which confirms focal uptake in closely adjacent nodal metastases rather than excreted tracer. The diagnosis in patient C is of complex multifocal primary disease demonstrating both low-grade and high-grade activity. This again could be distinguished from excreted tracer within a TERP defect due to contrast in the CT images. So in conclusion, selective delayed imaging improves diagnosis and clinical relevance. Skilled patient scheduling is required due to overcome the logistics of tracer preparation as well as other competing scheduling. Contrast usually identifies any defect from TERP if the prostate remains in situ. The presence of contrast within the course of the urinary tract at the prostate or prostatectomy bed helps distinguish residual or recurrent disease. Contrast differentiates between nodal metastases and excreted tracer in the ureters. The opacification of the urinary tract allows more confident assessment of recurrent and metastatic disease. The administration of iodinated contrast is easily included in an imaging protocol for gallium PSMA PET imaging. The optimum protocol does not impact on the logistical elements of a private practice as long as it is carefully scheduled. Thank you.
Okay, we're running a little bit late on this session, so in the interest of time, maybe if anyone's got any questions, they could approach Julie later on around the convention centre. I'm sure she'd love to have a chat.
I'd also just like to acknowledge Perth Radiological Clinic, which was where I was working when I put this presentation together.